So I titled this Support for Chronic Fatigue and Chronic Pain because they're both so widespread. I mean, so many people deal with chronic pain and chronic fatigue. There's not a day that goes by I don't talk to somebody who's dealing with both. And they go hand in hand. There's no doubt about it. You can go to the next slide. So what I'm going to talk about today, though, is other solutions and support than what's out there for chronic pain and chronic fatigue, because there are serious side effects. Pain, it can start at the level of the joint, what I have right there. So we know about osteoarthritis, just breakdown of the joint itself. That's going to cause chemical mediators, causes inflammation. And what that does is that's going to stimulate a nerve fiber, and that's going to go to the spinal cord, and that's going to go all the way to the level of the brain. That's where we feel the sensation of pain is at the level of the brain. That's why our opioids work so well, is they block that transmission of pain. And I have that down there. You can see that the level of spinal cord and the level of brain. The opioids, again, they're blocking us from feeling that pain. So why don't we just take the opioid? Well, they have a lot of side effects, and we know that. Dizziness, nausea, vomiting, respiratory depression, constipation. Also, delayed gastric emptying, immunologic and hormonal dysfunction. Hyperalgesia is actually an increased sensitivity to pain. Well, we're trying to decrease pain. That's the last thing we want, is an increased sensitivity to pain. There's a lot of studies of that. Long-term opioids. The thing is about the opioids is they're designed to take short-term. We're never designed to be taken long-term, but most people are taking them 1, 3, 5 years, even longer than that for their condition. And then the worst addiction. A lot of people we're having an epidemic of addiction to these opioid painkillers, and that's why we're seeing the epidemic with the heroin abuse. It's just widespread. Yeah?
What are some of the opioid painkillers of which you speak?
Hydrocodone, is one of them. We have Vicodin, ones that are used a lot. Anything in that category, go to the next slide. And here's an article I came across confronting the epidemic of opioid overdoses. You can see right there, 100 million Americans are suffering from chronic pain. That's the reason. But the only solution they're being given is these opioid painkillers. Again, just to block that sensation of pain. What I'm going to do, and why I did this presentation, is to educate individuals. Well, let's find out what is causing this pain. We know a lot of times that's from inflammation, just like I showed you at the level of that joint. You know about arthritis, you know about osteoarthritis, rheumatoid arthritis. We know that's destruction of the joints. We know that's causing inflammation, and that's what's causing our pain. And a lot of the solutions we're given is to suppress that inflammation, or just to block, again, that sensation of pain. And part of what I do is to give solutions other than those NSAIDs, those corticosteroids, those painkillers, without those severe side effects. Part of doing that is I show individuals, well, what's creating this chronic inflammation? Because I really want to empower people to really understand their own body, really at the cellular level. And I'll do a little bit of that today, because I really want to empower you to say, okay, here's what's going on, here's what's creating an inflammation. If you understand what's creating it, then you can intervene and give your body the building blocks to stop that inflammation without having these side effects. And you can, again, confronting the epidemic of opioid overdoses, and it talks about the death toll from opioid overdoses right there. In 2012, the last year for which data it says are available, almost 40% of American deaths from prescription drug overdoses were from opioids. That's a really high number. And what this article talks about right here is most people aren't just taking an opioid. They're usually taking it with another prescription medication. The problem with that is there's a lot of powerful interactions there that increase those side effects even more. A lot of times when the opioids are studied, or any drug is studied, it is studied in isolation, just that one drug. But what we don't know is what's the interaction of what they call polypharmacy, which is multiple prescription drugs interacting with one another. Most people, again, they're taking opioids with another prescription medication. And again, that's what it says there at the bottom, is most people aren't taking these short term. Well, they're studied short term, and they were designed to be just taken short term. Most people aren't. If you know anybody taking a painkiller, They've been on it, again, 1, 3, 5, 7, some people 10 years. Same thing right here. And this article was from 2015. I don't know if you can see that, but it's talking about how the DEA took your opioid painkillers, and you asked about someone, it talks about hydrocodone right there. They took it from a Schedule 3 to a Schedule 2, which makes it more restrictive. It makes it harder to get, harder to prescribe, which that's how it should be because they are so potent. But again, it's the addiction. That is what is so powerful. Andrew Kolodny right there, MD, President of Physicians for Responsible Opioid Prescribing, even said, in quotes right there, opioids are lousy drugs for most people with chronic pain. And that's the thing, it's one of the main solutions, but it's not really doing very well. It's not offering people much relief in addition to the side effects because we know they develop a tolerance, they get used to it. And that's again why we're seeing the heroin epidemic is people need to move to a more potent drug. But that's just talking about NSAIDs right there, of how they block the production of those chemical inflammatory mediators. They're called prostaglandins. I won't go into that in too much detail, but that's why when you see people take NSAIDs, you'll see like the GI side effects, whether that's like GI bleeding or they get the ulcers. Well, the reason for that is NSAIDs, they block the production of something called prostaglandins. You need prostaglandins to coat your small intestine, to coat your stomach. It protects the lining. So if you block the production of that, you don't have that protection of your GI lining, of your stomach. So that's why you get that ulcer. That's why you get that GI bleed. You need those prostaglandins. Unfortunately, they also produce pain. And that's part of what I do, is I don't want to suppress the prostaglandin, but I want it to be balanced. So there's more anti-inflammatory chemical mediators than there are inflammatory. And right here it talks about, I talked about their NSAIDs and their side effects with GI bleeds and ulcers of your GI tract. What this article is talking about here is what they're starting to find out is the side effects with NSAIDs and cardiovascular disease, especially with stroke, heart attacks, and it talks about the GI bleeding there too with the GI tract. But the reason for that is at the cellular level, NSAIDs are starting to produce, if you ever heard of reactive oxygen species or free radicals. That damages the cell. Well, if that damages, the blood vessels in the brain, it can lead to strokes or damage the cells within the heart. That's a big problem. That's what they're starting to see the NSAIDs are starting to do too, is cause these cardiovascular problems. Another article here talking about the side effects of NSAIDs with people, especially with leading to end-stage renal disease, affecting people at the level of the kidney. So I talked about before, where's this pain coming from? We're talking about chronic pain and chronic fatigue. And the side effects I went through talking about opioids and NSAIDs, a lot of the things are used for chronic pain especially. And I talked about their side effects. So what I'm talking about is how we can give support for that in other ways that don't lead to those side effects. And I was just telling them earlier, I really want individuals to understand, well, what's causing this chronic inflammation that's leading to this pain? Well, it can be something like injury, but two of the areas that I talk about a lot and that I treat in my practice is the gut bacteria within your gastrointestinal tract. We have a lot of gut bacteria. I tell people all the time, we have 10 trillion cells in our body. Everybody knows we're mainly cells, but we have 100 trillion bacteria in our GI tract. So we're mostly bacteria. And the question is that mainly good bacteria or is that bad bacteria? And that depends on how we support it and what we feed it. And the other thing that's causing this inflammation is mitochondrial dysfunction. If there's one thing I want to give you homework for, it's know what your mitochondria is. Just look that up. Just look up mitochondrial function and mitochondrial dysfunction. And just see the things that it leads to, whether that's Parkinson's, depression, a lot of your neurological disorders, bipolar disorder, ALS, myotrophic lateral sclerosis, which affects the motor neurons. But things, autoimmune diseases that cause inflammation, but then your cardiovascular diseases. Because we know our mitochondria, that leads to our energy production of our body. That's what gives us energy. It is our energy source. But if you look up mitochondria and you look up the conditions associated with mitochondrial dysfunction, you will be amazed. Like, I can't believe this. This is the source. This is what's going on.
Instead of us looking it up, or in addition to us looking it up, could you just explain what mitochondria is and does?
I will. Yep, absolutely. I got a picture of it too. Absolutely. So here, I told you about the gut bacteria in your GI tract. Well, that's what that picture represents right there. These cells right here, that represents the lining of your GI tract. And what it's showing right there is a break in that lining. And right underneath that lining, here is a lot of your immune system, a great majority of your immune system. The reason I show that is this causes a lot of our chronic inflammation right in our GI tract. What they call gut permeability, or a leaky gut. Well, if that happens, and we get bacteria that gets within, breaks that lining, or undigested food particles, that's going to stimulate our immune system right there. A lot of our rheumatological conditions, rheumatoid arthritis, ankylosing spondylitis, they'll use what they call the Tnf-Alpha Inhibitors. Anybody ever heard of those? They're the biologics. Very powerful for taking down inflammation. And I show this picture because you can see right there, it's hard for you to see, but it's TNF-alpha. That's where that inflammation is being produced. That's where that TNF-alpha is being produced at the level of the GI tract. And I educate individuals all the time that we can suppress that TNF-alpha from attacking the joint and causing the pain, but it's being produced because there's damage to the lining of that GI tract. We have to heal that lining to stop that inflammation from being produced.
And how do we do that?
I'll show you. I'll show you some of those interventions that we can do. You go to the next one. So that gut bacteria, so I showed you that lining. On top of that lining, that is the bacteria. It lies right on top of that lining I showed you. Well, it's made up of good and bad bacteria. Like I said before, we got to make sure the majority of that is good to keep that lining intact. Because when there's a majority of bad bacteria, that's what causes that break in that lining. So to your question, we got to make sure there's enough good bacteria to nourish that lining. That good bacteria, like it says here, produces vitamins, B12, K2, which are very, very important. It's very anti-inflammatory. So we're talking about inflammation leading to this pain. We need things that are anti-inflammatory. Well, that good bacteria is very, very anti-inflammatory. It nourishes that cell lining. It also modulates our immune system so it doesn't attack our joints. It keeps it in balance. It also produces neurotransmitters. You've probably heard that serotonin is implicated, a deficiency of serotonin is implicated in depression. So somebody given a medication so they have higher levels of serotonin, so they don't have that depression. The thing is over 90% of that serotonin is produced in our gut, in our GI tract. So you can see how important it is, even in neurological conditions like depression, we have got to support our gut, our GI tract. We got to nourish that with good bacteria. Hormones, also, a lot of hormones are produced in our GI tract. Very important. People will come to me all the time and they'll say, well, my hormones are out of balance. And I'll say, well, let's look at your digestive health. Let's look at your gut health. Like, well, what's that have to do with my hormones being out of balance? And I'll say everything. Because there's so many of your hormones are produced there. So you can see neurotransmitters like serotonin for neurological conditions, and then hormones are all produced in our GI tract. Very, very important. This is just a picture here, what I was talking about, how that gut bacteria keeps your immune system in the balance. So you ask, well, how can we nourish that lining? How can we make it strong? How can we make it intact so it doesn't have that break, so it's not leaky? Well, nutritional medicine is one of the mainstays of my practice. And it's feeding it the foods that are going to feed the good bacteria. Of course, that is a lot of our vegetables, no doubt about it. They feed the good bacteria, they help them reproduce. What's going to feed the bad bacteria? Number one is sugar. There's no doubt about it. That's why you're hearing all the time, man, sugar is bad, it causes inflammation, obesity, diabetes, and it's true. The sugar, and one of the main reasons is that sugar is fuel for that bad bacteria in your GI tract. The bad bacteria grows, it damages that lining, it disrupts the immune system attacks different organs in different people. Some people, that can be brain tissue, so we get neurological conditions. Some people, that might be the joint, and that's where we can get our arthritis, our rheumatoid arthritis, and different inflammatory conditions that are attacking us at the level of the joint. But I'm showing you what's the source of this though, what's producing this inflammation. It is at the gut, and it's what we're feeding that bacteria. Are we feeding the bad, or are we feeding the good? L-glutamine is great. I use that a lot because it's one of the main fuel sources. You remember that when I showed you the lining of the GI tract and those cells? Well, L-glutamine is the main fuel source for those cells. If they don't have their main fuel, enough L-glutamine, then again, they're going to break down. There's going to be a break in that lining. They must have their main fuel source. That's why L-glutamine is so popular for GI conditions, to heal that gut lining. Botanical demulcents, there's different things. You might have heard of DGL, aloe vera, marshmallow, not the marshmallow you're thinking of, not the one you roast on the campfire, but it's a botanical demulcent. And vitamin A and zinc carnosine, again, because they help those cells lining that GI tract, they help them stay tightly together. Because again, we don't want to break there. And all of those help those junctions stay so there's not a break, so it doesn't let that pathogenic bacteria and undigested food particles in to stimulate the immune system. Yeah.
Is the L-glutamine in certain particular foods, or are you talking about supplemental?
A lot of times we give it supplemental because it's so much more absorbable. It can be in a capsule or even powder. It can be in a lot of foods too, especially your protein-rich foods. But the question is, if we have somebody with a digestive disorder, they might have trouble breaking that food down, digesting it, absorbing it. So it can be given in supplemental form. A lot of times, like I said, a powder, because that is already broken down. It's just straight L-glutamine, so it's absorbed by that cell and is used immediately. So that was the GI lining. Remember two things I said, where is this inflammation being produced? Well, the first one I took you through is that GI lining. And I showed you how the immune system can be stimulated under that GI lining. That's the first place that a lot of this inflammation is being produced. It's leading to our pain. Another area, I'm going to kind of switch here, is I told you about the mitochondria. You asked, well, can you show us mitochondria? Can you explain it to us? I'll use the analogy, okay, let's take a car, and it runs from its engine. You got to have an engine in a car for it to run. So I want you to look at the mitochondria in our bodies like an engine is to a car. We got to have our mitochondria to move, to do anything, to breathe, to have energy. We got to have our mitochondria, and they must be functioning well. For mitochondria to function well, to give us energy, just like an engine makes a car move. You don't have an engine, or if you do have an engine and it's not working very well, or if you give a car anything other than gasoline, or not top quality gasoline, that engine is not going to run as well as it should. The car might run, but it might only go 20 miles an hour. But it has the ability to go 70, 80, 90, 100 miles an hour if that engine's really, really good. Well, just like with us, if our mitochondria, our engine, are supported very, very well, if they're given the building blocks they need, we'll run very, very well. We'll have more energy. Our mitochondria are our engine. And this picture here depicts part of the mitochondria. And one of the things I want you to see here right there is CoQ10. That's one of the main building blocks your mitochondria need to produce energy. Very, very important. So mitochondrial deficiencies, what are the building blocks to make your mitochondria function at their best for you to have energy? CoQ10 is one of the main ones. L-carnitine, magnesium, D-ribose, and a lot of your B vitamins. You must have these building blocks for your mitochondria to function optimally. If you're deficient in any of these, we get chronic fatigue. That is going to be a result of our mitochondria not having the building blocks it needs to produce energy. Also, when our mitochondria, when they produce this energy, well, as a byproduct, they produce free radicals. You might have heard of free radicals. That's why antioxidants are so popular because they counter the free radicals in our body. Free radicals cause inflammation, they cause damage to our cells, our organs, our tissues, even our joints. So what happens is if we have deficiencies in antioxidants, we're going to get too much free radicals. That's going to cause inflammation. That's going to cause pain. What are some of the antioxidants we need? We might be deficient in vitamins A, C, E, N-acetylcysteine. And the great thing is about CoQ10 and L-carnitine, not only are they used for us to produce energy, they're also very, very powerful antioxidants in addition. So they have a dual role. They produce energy for us, and they protect us from the free radicals and inflammation. Other antioxidant deficiencies we might have: selenium, zinc, copper, manganese. Right here it talks about, you've probably heard of fibromyalgia. Since I deal a lot with chronic pain and chronic fatigue, you better believe I deal with fibromyalgia. Chronic fatigue and pain is two of the mainstay symptoms of that condition. What this article is talking about right here is what I've just been telling you about. We know with the chronic pain, with the chronic fatigue and fibromyalgia, inflammation is the cause of that. What this article is talking about, and what I've been telling you, is what's causing the inflammation in fibromyalgia that leads to the chronic pain and fatigue. This research article says mitochondrial dysfunction. Right there. Is inflammation a mitochondrial dysfunction dependent event in fibromyalgia? In this research article, they're finding yes, it is. We have the inflammation that leads to chronic pain and fatigue. Where is this inflammation coming from? Dysfunctional mitochondria. And what they really focus on here is all the inflammatory cytokines we talked about increased in these patients. Also, the reactive oxygen species I've been talking about, those free radicals, those were increased, but what was decreased? In this research article, you can see right there, in those patients, what was decreased was CoQ10, for all those reasons we just talked about. If you have a deficiency in CoQ10, our mitochondria will not work the way they should. That will cause inflammation, that will cause pain, and that will cause fatigue. Again, talking about fibromyalgia, just the things we see in it: pain, fatigue, headache, sleep disturbances, even depression. And again, we don't never, do I want to say never? I do want to say never. Do I see anything just in isolation? I will not have somebody come to me and just say, well, I have pain, but I don't have fatigue or anxiety or depression. No, it's almost always linked. I have pain, but you know what? I have fatigue. You know what? I'm depressed. Oh, I have anxiety too. Oh, and by the way, I can't sleep that good. It might not be on their intake form, but when I ask questions and I dig a little deeper, it's amazing the things that come out. Because why? Because you cannot put our body in isolation. You can't just say, oh, well, my knee and it's pain. And that's separated from my brain, that's separated from my heart, that's separated from my kidneys, my liver, my pancreas, my GI tract. Everything's connected. That's part of my approach too, is looking at everything combined, the whole body. Just talks about here more of the deficiencies in fibromyalgia and mitochondrial dysfunction. You can see the deficiencies. Again, all of those building blocks your mitochondria need for energy: CoQ10, L-carnitine, the B vitamins, magnesium. Very powerful. Just a picture, the root of pain right here is the damaged mitochondria, and you're asking about what's our mitochondria. That's a very good depiction of what the mitochondria in your cell look like. The one on the left is a damaged mitochondria, and the one on the right is a healthy mitochondria. Yes?
So do you feel that when you supplement with things like CoQ10 and things, that obviously helps, but what's the right, you see I have fibromyalgia, and in the beginning all my doctors wanted to do was throw me on these opioid meds, and I refused it. I said I'll learn to overcome it, mind over matter, versus to take those things, because I didn't want to end up in a rubber room getting detoxed from it. I started on my own taking CoQ10, and I found that it wasn't the end all to be all, but it helped. But no one's ever told me, how much do you need of these extra things to build yourself naturally versus just block the pain and live with it?
Yeah, and it's a great question and a great point, because CoQ10 is, you can see, one piece of the puzzle. You got a response because your body desperately needed CoQ10 for energy production and to reduce that pain. The question is, what else did it need? You can see how much I talk about that inflammation being produced at the level of the gut, and then how many more building blocks that mitochondria need. And then there's so many things, I'll talk about a few more things, but beyond this that can be done. And it's putting all that together, and then the clinical response that we see and that I see is amazing when we start giving the body those right building blocks. And that's why I do this lecture, and I go into this detail. And I'm glad you guys are asking questions, because that shows me, okay, you're following, you're getting it. Because part of what I want to do is to educate and empower you. Like I can see right there, you said, okay, CoQ10. I went out, I got that. I'm seeing why it helped. What more can I do? But I'll find out people have got to understand how their body functions. You've got to be empowered. I mean, as a physician, yes, I have to know it to the nth degree. But I also want individuals who aren't physicians to understand how their body works. I want you to be empowered, so you don't have to be relying on that to say, okay, I've been given this option. I don't really feel comfortable going down that road. It has severe side effects. I'm not saying it's not needed. Sometimes they are in the short term. Part of my mission is to show people you have other options in addition to that or instead of that. But I like giving individuals the option to choose. And I believe that empowerment comes from you understanding how your body functions at the most basic level. Then you can say, oh, wow, that makes sense. Why I need those building blocks for that to work. Good question, good point. So here, this is kind of the biochemistry. I told you I like to educate. But I was a teacher before I went back to med school, so that's why part of my passion was there for 6 years. This is the biochemistry of CoQ10, and what I really want you to focus on is up here. That's an enzyme that leads to the production of cholesterol. And I put this up here because almost everybody is familiar with statin medications to lower cholesterol. And I give another lecture, and it's about cardiovascular risk factors. And I really go into detail in that lecture about this, because an individual will have an increased level of cholesterol and will be put on a statin medication to reduce that cholesterol. Almost every time I have the audience raise their hand, it was a few months ago, and it was at a healthcare center, and it was the healthcare practitioners, about 60 of them. And I said, how many of you know somebody who's on a statin and they experience muscle pain and fatigue? I bet you 3/4 of that room raised their hand. It was unbelievable. And I said, do you know why? And they didn't. This was nurses, some of them were residents, and then most people didn't raise their hand after I said, do you know why? And I brought up this picture of the biochemistry of CoQ10. And I showed the statin medication, and I showed it reducing cholesterol. I don't know if you can see it. Can anybody take a guess of what else statins decrease the production of, in addition to cholesterol, of why somebody experiences fatigue and muscle pain? What else do you think statins deplete? CoQ10. And I show this picture because it's the same biochemical pathway. This enzyme right here, HMG-CoA reductase, 3-hydroxy-3-methyl-CoA reductase. That is the enzyme statins inhibit to reduce cholesterol. The problem is, in the same exact pathway that we're reducing cholesterol, the same pathway we reduce CoQ10. And right in that picture it says, CoQ10 deficiency caused by statins can lead to congestive heart failure, chronic myopathy. That's just disease of the muscle. That's why we get the muscle pain. And look at that, chronic fatigue syndrome. Well, now you know why. If you deplete CoQ10, now you have the knowledge of why. That makes sense to you. You go out and you meet somebody, like, yeah, I've been telling you, I'm not saying they don't need the statin. I'm not saying that. But by God, supplement them with CoQ10. I mean, that surprises me every time I hear that. If somebody's on one, okay, I'm not necessarily going to argue that, but let's support them with CoQ10. And you guys now know if we deplete CoQ10, you would say, well, of course you're going to get muscle pain and fatigue. Why wouldn't you? Same biochemical pathway, decrease cholesterol, decrease CoQ10. Got to supplement that CoQ10. Right here, research article, coenzyme Q10, talking about right there in the bold, CoQ10 utilized for energy production. You guys know all about that. You know you must have CoQ10 to have energy production. And I bolded it right there, CoQ10 deficiency, congestive heart failure, hypertension, Parkinson's disease. Why? Because we're affecting at the level of the mitochondria. And that might be neurologically, the mitochondria within the brain tissue itself. So you can see if we reduce that CoQ10, we're going to affect that mitochondria. Well, then I hope at this point you're saying, no wonder we have all these problems. If we have these deficiencies and we're disrupting our mitochondria, well, yeah, it's going to lead to pain, fatigue, neurological conditions, heart failure, hypertension. That is my goal. If you say, oh, no wonder. L-carnitine, I talked about that being supportive. Again, this just shows for people who are interested, the biochemistry of L-carnitine and why it gives us that energy production within the mitochondria. Just here's a research article. What I like to do is I like to show, okay, here's the mechanism, here's a picture, here's why it does what it does, and then I like to back that up with research. And you can see right there, L-carnitine utilized in the production of cellular energy. And I like this down here, it talks about L-carnitine, and it says it's so neuroprotective. Neuroprotective being our brain for those neurological conditions, and it's because it's such a powerful antioxidant. Remember what I said about CoQ10 and L-carnitine? Not only are they really, really good for energy production, but they're also very powerful antioxidants to help with those free radicals to take down that inflammation. And that's why it takes down pain. Talked about this, cofactors for energy production. You should know them very well by now. CoQ10, L-carnitine, B vitamins, magnesium, zinc, manganese, and iron. Why? Those are cofactors for enzymes as part of energy production. Anybody who talks about this stuff, because it's one of the things that actually frustrates me, it's one of my pet peeves. I'll tell somebody that I'm a naturopathic physician and they'll say, I believe in that. Like, I think that's really neat. That's great. I believe in it. And I'm like, well, you don't have to believe in it. It's not something you believe in. I say, especially the medicine that and I hope you guys can see this, the medicine that I practice, it's just based on the physiology of your body. I have just taken, here's how your body normally functions. Like we were talking about the mitochondria or the GI tract. And I said, well, okay, if this is how the body normally functions, and these are its building blocks, what do we need to support that? If you're deficient in those building blocks, then your body's not going to function normally. So I'm just providing building blocks for it to function normally that don't have side effects. Because my aim is not to inhibit something, it's not to just suppress your symptoms, but to support your body at the most basic level so it gets stronger. Supporting that mitochondria, supporting that GI tract. So I hope you see that it's not, something that can be interesting or something that you believe in. It's your physiology. It's the normal function of your body, and I'm supporting that. What this is a very complicated picture, but it's kind of, you see at the top, fats, carbohydrates, proteins. What that is, that's the food you eat. So our mitochondria, what it does is it takes nutrients from the food you eat, and then oxygen you breathe in, and then it produces energy. And what they call that is ATP. That is the energy production of mitochondria. But again, we eat food, our body hopefully in digestion absorbs nutrients from that. We breathe in the oxygen, and our mitochondria utilize that for energy. And for your mitochondria to do that, I hope you can see you've got to have all those building blocks. The reason I put this up here is it's one of the panels that I'll run in my practice. It's called a NutriVal. And it's blood, but it's also urinary. And what they're looking at, because you're probably thinking at this point, okay, well, how do I know? How do I know that I'm deficient in those building blocks? And that's a great question. And like I said, that's why I run that NutriVal, because what it will show me is if somebody is sufficient in those nutrients, if they're borderline, or if they have a high need. It will show that. And so I can supplement for that individual for what they need. There might be a high need in B vitamins, but they might be borderline in magnesium, and their CoQ10 might be sufficient. It might be okay. So it can guide us for each individual. It's a very powerful intervention. Talked about the need for antioxidants. We talked about that a lot. Two of the ones I didn't talk about, though, that are powerful antioxidants are resveratrol, you might have heard of, and then alpha-lipoic acid. Here I just have that because we're supporting the mitochondria, but you also got to support that cell membrane around the cell. That's why omega-3 fatty acids are very, very helpful. They help balance the inflammation, and they're also a building block. Again, as you hear omega-3 fatty acids, do they really work? It's popular, is it just a fad? Well, I like to show people that, yeah, it's a building block. It's a building block for your cellular membranes to keep it healthy. causes chronic fatigue, and just lists it there. So it can be the deficiencies that we talked about. You know that. Pain itself will just cause fatigue. If you're in chronic pain all the time, you just want to lay around the couch. You don't want to do anything. Chronic inflammation, lack of exercise, lack of sleep, all can cause chronic fatigue. We still okay on time?
Yeah.
Is everybody okay?
I'd like to know what potencies that CoQ10 comes in.
Yeah, and that's
Is it one potency or there's several?
There's several. Most of the time it can be 50 milligrams, 100 milligrams, or 200 milligrams.
And what do you recommend?
And you bring up a great point. So what I would do is usually run that NutriVal test and see if somebody is sufficient, but they might just need support, maybe at 50 milligrams, maybe 60 milligrams. If they're borderline, maybe they need 100 milligrams. If they have high need, they might be somebody who needs 200 milligrams. Then you have to take into consideration their history, their background, and what condition they're presented with. So if I see somebody who has maybe a borderline need, but let's say they have a cardiovascular condition. Okay, maybe in the past they had congestive heart failure, or they have hypertension, or they have high blood pressure. That person's going to need a higher dosage to have support for their heart. So it's really going to depend on the individual, their condition, how long they've had it, and then the results of
And you
any
should
test.
see results from right away?
Oh, from supplementing with it? That again will depend on the length of time they had it. So some people can a couple weeks, some people take a couple months, some people take 3 or 4 months because it's got to build up. So it really will depend on how long do they have the condition, how severe is it. And that's where each individual's past medical history and current condition really go into play. So I usually end with a case. We have a 20-year-old male. Kind of ties together everything that I've been talking about, and it shows the power of it. That's why I end with this case. But so we had a 20-year-old male who started out with right-sided low back pain. You probably either experience or know somebody who deals with back pain. Very, very, very prominent source of our chronic pain. But this was a pretty young individual, 20 years old, and very active, played a lot of basketball, worked out. One day playing basketball, he experienced some pretty bad pain in his low back. Thinking, okay, I just did something working out, playing basketball, no big deal, I'll just rest it. Pain kept getting worse, pain kept getting worse. Over time, this individual could actually barely walk. Every step was pretty excruciating. So he eventually went to a sports medicine specialist. They took an x-ray of his low back, and there were degenerative changes in the low back, what they call the sacroiliac joint. It's where your sacrum right here, that your low back, meets your spine. It's at actually the base of your spine. And there's a joint there, what they call the sacroiliac joint. And you can see the degenerative changes on the right side. It was different than the left side. There's no doubt about it. The sports medicine specialist sent this individual to a rheumatologist. And the rheumatologist made a diagnosis of rheumatoid arthritis. Imagine, 20 years old, this was pretty devastating for that individual. Like, how could I have this at such a young age? But the rheumatologist used the tools that he had, that he knew very well meaning, which were the NSAIDs. Those worked for about 3 to 4 months. They were very powerful for this individual. It's like, wow, that pain is reduced. If you've taken an NSAID or know somebody has, they do work pretty quick of taking down that inflammation. You do have a reduction in pain. You have better mobility. So this individual could start, doing things again that he was able to do, playing basketball, working out. The problem is, after about 4 months, the pain came back. Went back to the rheumatologist, saying, well, these were working, but it's not as effective as it was. And we talked about building up that tolerance. Individuals eventually put on the opioid painkillers that we talked about. Vicodin, actually very powerful opioid. Just one at first. That again took the pain level down. Again, worked for about 3 to 4 months, but then it wore off. Individual goes back to the rheumatologist, says, listen, it worked great, but now the pain is back again. I don't have that same mobility. It's getting worse. Different NSAID. The individual was put on a higher dosage, trying a different NSAID, and then eventually put on more opioids. And then when they didn't work, periodically put on corticosteroids to try to knock down that inflammation for a time period. It was only about 1 to 2 weeks of the corticosteroids, but that would happen, especially when there were flare-ups. This individual also experienced, extreme malabsorption and a lot of fatigue. Had pain in the spine, the ribs, low back, hips, and knees. There's a lot of this where the pain was in this individual. The diagnosis after it was about 10 years was actually switched to ankylosing spondylitis. Most people haven't heard of that condition. It's pretty rare. Most people haven't heard of it. But what it is, it's unlike rheumatoid arthritis you've probably heard of. Rheumatoid arthritis will attack your wrists, the hands, the ankles, the feet mainly. It can attack any joint, but mainly the joints that they call on the periphery of the body. Ankylosing spondylitis is different because it's mainly inflammation of the entire spine. It can attack the whole spine, again, the ribs, and mainly the hips, what they call the axial skeleton, right in the center, as opposed to the hands and feet of rheumatoid arthritis. So the diagnosis was eventually ankylosing spondylitis in this individual, but with the medications, some of them are similar to rheumatoid arthritis, like the NSAIDs and the opioids. This shows you everything that individual went through. So that was about age 20 years old. 6 years later, at 26, things really started to get worse and go downhill for this individual. Mind you, this is 6 years after the painkillers, the NSAIDs, the corticosteroids. Now the individual starts getting extreme anxiety, fatigue, headaches, heart palpitations, you name it. That kind of goes back to what we talked about earlier, that these things don't happen in isolation. You usually see a lot of symptoms and pathology together. So a lot of blood work was done, EKG, they put the suction cups on your chest to track the electrical conductivity of your heart, chest x-ray, MRI in the brain, EEG, where they stick the things to your head to measure the brain waves. Everything came back negative. Individual was diagnosed with anxiety attacks, put on Ativan, other anti-anxiety medications. The patient was on these for about a year, and after a year, it just couldn't take them because it just couldn't function normally. So the turning point came 7 years later, at the age of 27, being on these opioids, these NSAIDs, these corticosteroids, the individual goes back to the rheumatologist and says, listen, I'm in extreme pain, I can barely walk, the pain at night, it's horrendous, I can't sleep. Rheumatologist says, I'm sorry, there's nothing else I can do. I have tried every medication, we've tried every dose, every name, we've put you on the highest dose of the opioid painkillers that I can, the corticosteroids aren't doing it. There's nothing else I can do. You're too young to put you on a higher dose of medication. It will ruin your liver. You're just too young, 27 years old. That was a turning point for this individual because this individual was given no other options, pretty much just on their own at this point. So what this individual did is just on their own started researching natural therapies. Okay, I don't have any other options here, but I'd like to improve my quality of life without constantly experiencing these side effects. So the individual researched anti-inflammatory foods, we kind of talked about that a little bit, but supplements and certain exercises that would take down this inflammation, that would help with this pain. So the patient eventually got off of all of the prescription medication, which should always be medically supervised and guided. I mean, that has to be a slow process. And that's what this individual did over a course of a period of time, very slowly, weaned off all the medications, very safely, very slowly. So the pain was still about a 6 to a 9 out of a 10, though. And the flare-ups that happens with autoimmunity, with chronic inflammation, were happening about twice a week. When the flare-ups were there, the pain was 10 out of 10. The individual could barely walk, could barely get out of bed. But it was a success because he was off the prescription medications, but still in a lot of pain, but just being able to live without being dependent on them. So after about 1 to 2 years of these natural therapies, of this anti-inflammatory diet, this nutritional protocol, these supplements, these exercises, taking down the pain, progress was made. The pain, you can see though that this does take time. The individual had it for 7 years. So when you take that in the context of 7 years of having this, 1 to 2 years, that is a long time, but it's still progress is made that quickly after 7 years. That's still really good. So pain goes down to about 4 to a 7 out of 10. Instead of the flare-ups being twice a week, now they're only twice a month. So we're seeing continued progress here. Still taking over-the-counter Excedrin when there were flare-ups to be able to sleep at night. But we know, and I talked about that, what that can do to the GI tract. So you would see occasional blood in the stool from the damage that was doing to the GI tract. So what is the patient's current treatment? It's an individualized nutritional protocol where this individual is right now. And again, so why does this nutritional protocol work? And you guys know that very well now, is to heal the gut lining and to shut off that chronic inflammation. That's what this individual did. That's why the progress was made without those medications, because the individual was supporting the body at the source, at the most basic level we talked about, and that's healing that gut lining. So that shut off that chronic inflammation, and also the mitochondrial support. The individual started to support the mitochondria to give the building blocks for that energy production. So those two things were done. And then a specialized exercise program called foundation training. And remember, this individual's condition was inflammation of the entire spine. What that disease eventually does to somebody, I'm standing here straight up, but ankylosing spondylitis, because it's constant inflammation and breakdown of the spine, it takes the body in the posture and like this. If you ever seen anybody, walking like that, they might have had AS. Because that chronic inflammation, it fuses the spine together. You should have your vertebrae, a disc, and a vertebrae. Well, that shouldn't be solid and all fused together. But because of the chronic inflammation in the spine of these individuals, it fuses the spine. So once they're in that posture, they can't come out of that, so they'll walk like that. That's what it does. It constantly breaks it down. So that's why this exercise program foundation training was so effective for that individual, because it strengthens the muscles of the back and it supports the spine to keep them like this. Because when we're driving, we're sitting, we're like that. But for somebody with this condition, it is essential that they stay upright. And that's what that did. You can see right here what they call the muscles of the posterior chain in our back. So whether that's our hamstrings, our glutes, and all of our back muscles, if that's strengthened, that'll take us out of this posture and bring us into this. And that's very important, because when our posture isn't correct, when we're not upright, that causes a breakdown of those joints and those discs in our spine. And again, so if any time we have that breakdown, that's going to lead to the inflammation, and then that's going to lead to pain, because it's part of that degeneration. So if we bring our posture from this to this, well, that brings that spine into alignment of how it should be. Then we slow that degeneration, we slow that breakdown. We stop the inflammation, we stop the pain. So you can see that it's internal, the nutrition, the mitochondrial support, but then external too, with those exercises. It was very powerful. So where is this patient today after all those interventions? So remember, I told you from age 20 to 27, the individual is on those medications, those NSAIDs, those opioids, those corticosteroids. And you can see all the things that started to happen. Well, we started with the chronic pain, we had chronic fatigue, we had extreme anxiety, we had headaches, we had heart palpitations, all those symptoms from age 20 to 27. Today, where this individual is from age 27 to 36, so that's a 9-year period now. We had a 7-year period where they kept getting worse, worse, and worse. Well, for the last 9 years, this individual has been on no prescription medications. Even more than that, they have the least amount of pain they've ever had in 18 years. That pain fluctuates from a 0 to a 2 out of 10. This individual, for about 15 years, never thought they'd experience a day without pain. Never thought that it would be possible. So the fact that they achieved a 0 out of 10 pain after 15 years living in chronic pain, it is absolutely life-changing. A lot of people say it's too extreme. They say, well, that nutritional protocol is supporting your body in that way, like we talked about the GI tract, the mitochondria, doing that certain exercise program, they say to that individual, that is too extreme to keep that up. And I say it's not, because that was my case. If I am the individual in that case, that is my story. That's what I went through. And over 15 of those years, This is what it felt like to live in my body. I have ankylosing spondylitis, and I've had it for almost 18 years. But 15 of those years, that was my life. I know what it's like to live with chronic pain. I know what it's like to live with chronic fatigue. And today, my life is like that after 18 years. Thank you.